Thank you very much for joining us today. My name is Dr. Seth Baum. I'm a former interventional cardiologist and electrophysiologist turned preventive cardiologist and lipidologist. And today we'll be discussing interventional prevention, which is a subject near and dear to my heart, a novel approach to cardiovascular prevention. Welcome. There are three windows we utilize to peer into the active and dynamic elements of cardiovascular risk, and they are vital elements for practicing modern day prevention. These will be the subjects that we will discuss today, and they include lipoproteins and lipids, biological markers, and imaging. Let's start with lipoproteins and lipids. And there's a critical distinction that must be made here, and this distinction, in fact, can be life-saving. Typically, we look at LDL cholesterol. Everybody knows about LDL-C or LDL cholesterol. It's on every lipid panel that's ever done in the nation and, frankly, around the world. Well, LDL-C tells us how much cholesterol is contained in the sum total of all LDL particles. But LDL-P, or LDL particle number, actually tells us how many particles an individual has. This may at first blush seem like an inconsequential or an unimportant distinction, but in fact, it is a critical distinction that enables us to practice truly life-saving prevention. Let's look back at the origin of our understanding of cholesterol and its role that it plays in plaque formation. Well, in the early 1900s, a medical student named Anichkow was the first individual to demonstrate the causal relationship between cholesterol feeding and plaque formation. In about the 1940s and 1950s, through analytic ultracentrifugation, we developed the ability to actually analyze the cholesterol content of the various lipoprotein particles in our bodies. And we also recognized that the lipoprotein particles were the most critical element of lipids and lipoproteins. It's the lipoprotein particles, in fact, that carry lipids, being cholesterol and triglycerides, from one part of our body to another. The problem was that analytic ultracentrifugation machinery was so complex, so expensive, and so cumbersome that we couldn't have these machines all around the country. So it was decided that LDL cholesterol, again, the cholesterol content of LDL particles, would become our gold standard by default. It was not chosen to be our gold standard. It was by default because it was very, very easy for us to analyze how much cholesterol was contained in these particles, and that, in fact, could be done around the country. Let's not forget, however, that the particles are, in fact, more important than the amount of cholesterol because the particles are what cause plaque. This next slide demonstrates prospective cardiovascular outcome trials, which look at LDL cholesterol, ApoB100, and LDL particle number. And there's a uniformity of results here. And the uniformity is that in every one of these clinical trials, it has been found that LDL particle number is superior to LDL cholesterol in identifying the atherosclerotic endpoint. And these endpoints can range anywhere from myocardial infarction and angina, death, sudden cardiac death, to angiographically depicted cardiovascular disease. Here we see a schematic representation of a typical lipoprotein particle. And on the left, we see the lipoprotein particle sliced in half. The outer part of the lipoprotein particle has phospholipids, and the inner part of the lipoprotein particle is the cholesterol and triglyceride, that's the cargo that's actually being trafficked around the body. Now, the phospholipids are very important in that they have a property called an amphipathic or amphiphilic property, meaning that one end of the phospholipid is hydrophilic and the other end of the phospholipid is lipophilic. as our blood is an aqueous solution, the hydrophilic ends of the phospholipids are in contact with our blood, while the lipophilic ends of the phospholipids, and those are those two strands hanging down from each phospholipid, those are in contact with the cargo, which again is cholesterol and triglyceride. So this enables this very, very important cargo of cholesterol and triglyceride to be, again, trafficked around the body. Now, on the right side of the screen, you see a particle in its entirety, and the importance here is that you see this very, very large protein wrapping its way around the surface of the lipoprotein particle. And in this case, it's ApoB100, which is a very large protein, and ApoB100 is in a one-to-one relationship on every atherogenic particle. So it's on VLDL, it's on LDL, it's even on Lp(a). So we know that LDL particle number is important. LDL cholesterol is important too, but we know that LDL particle number actually predicts better cardiovascular outcomes. And it's important to understand that in individual patients, we can often find what's called a disconnect between LDL particle number and LDL cholesterol, meaning the relationship that exists in this individual is not what we would anticipate from our population-based trials. And the two trials that are most important here are Framingham and Mesa. Framingham looked at LDL cholesterol, while Mesa looked at LDL particle number. And you could see that the 20th, 50th, and 80th percent of the population with pretty much a bell-shaped curve will have 100, 130, and 160 milligrams per deciliter for LDL cholesterol, while the numbers for LDL particle number will be 963, 1222, and 1514. Now, nobody's going to remember these numbers for LDL particle number, but if you pay attention, you'll see that there is approximately a 10-to-1 relationship between LDL particle number and LDL cholesterol. So if you have an individual patient, for example, who has an LDL cholesterol of 100, you would anticipate that that individual would have an LDL particle number of 1,000. And if you had somebody with an LDL cholesterol of 130, you would anticipate that he or she would have an LDL particle number of 1,300. And when we see a large discrepancy there, where there's what we call a disconnect, this becomes very important when we evaluate our patients in clinic. The next slide shows us the pathophysiology whereby LDL particles are actually entering through, or rather between endothelial cells, and then entering the intima where they wreak havoc upon our bodies by creating plaque. So if you go back to some basic science, you'll recall that gradients are very, very important. And if you can imagine, if you had a lot of LDL particle numbers floating around in the bloodstream, there's going to be a greater likelihood that they're going to actually bang into the endothelium and then go through or between the cells and then be held on within the intima, held on to by proteoglycans. These LDL particles then become oxidized, and frankly, after they become oxidized, many terrible things occur, one of which is an enzyme that rides on LDL particles, an enzyme called LPPLA2, or lipoprotein-associated phospholipase A2, will become activated and will actually cleave a phospholipid that is on the surface of this LDL particle. The byproducts of this cleavage are actually two very potent and dangerous lipid byproducts, which end up causing greater oxidation and greater inflammation, the release of cytokines and chemokines, and then the monocytes that come in, again, between these endothelial cells and become macrophages will gobble up the oxidized LDL particles, become foam cells, and basically you have a highly inflammatory, a highly active milieu whereby plaque grows very rapidly and dangerously. Next, we'll evaluate biological markers an essential element when one is trying to practice truly patient-centric cardiovascular prevention? Here you see a slide that I've used for some time actually, and it's one of my favorite slides. It's a slide of a bicycle because the frame of the bicycle represents the non-modifiable risk factors: gender, genetics, and age, whereas the spokes of the wheels represent modifiable risk factors, those risk factors that we can actually do something about. And the reason this is important is that, look, we can't do anything about the frame of the bicycle, but we can clip each of these spokes because cardiovascular disease really is a multifactorial disease. And in order to do some significant damage to the prospect of your patient developing a heart attack, stroke, or death, to nullify that possibility, we have to go after each one of these cardiovascular risks. And here you see what they are. Well, we all know about hypertension, hypercholesterolemia, but there are other ones as well. Things like low omega-3 levels, or just like we discussed a moment ago, LPPLA2, lipoprotein-associated phospholipase A2. But what we have to do really is be able to determine whether or not these are just biomarkers, or are they risk markers or even risk factors. Risk factors being the most significant of the three, those that have a clear causal relationship, and those factors whereby when we actually diminish them, they will result in a reduction of cardiovascular events. And that's a very important distinction, and one which we will now discuss. So the American Heart Association has a very tight framework to establish risk markers of cardiovascular risk. So this will elevate the biomarker to the risk marker. And there are 6 elements here, and they are proof of concept, prospective validation, incremental value, clinical utility, clinical outcomes, and cost effectiveness. And it's interesting that cost effectiveness is actually included in this scheme. And so when we evaluate something like LPPLA2, for instance, we need to go through each of these steps from an American Heart Association standpoint in order to determine whether or not it meets the criteria in order to become a true risk marker. When we look at lipoprotein-associated phospholipase A2, it is clearly a biomarker for rupture-prone plaque. LPPLA2 is a vascular-specific inflammatory marker, and it is absolutely critical in the formation of rupture-prone plaque. And as we all know, rupture-prone plaque is the main culprit in causing a heart attack. So when one experiences a heart attack, one has a plaque which fissures, ruptures, and then a clot forms, and LPPLA2 is an integral part of that process. LPPLA2 is actually FDA cleared, and it's a commercially available blood test, and frankly, it's the only blood test available and approved for predicting both heart attack and stroke. It's known as the plaque test, or PLAC test. The next slide is a forest plot demonstrating the impact that LPPLA2 has with regard to cardiovascular disease risk. And here you can see that overall, elevated LPPLA2 levels will double cardiovascular disease risk, and that's based upon a multitude of clinical trials. So based upon what I just showed you, and frankly there are other trials as well that meet the AHA criteria, LPPLA2 is in fact a risk marker. But then the question becomes, yes, it's a risk marker, but is it a true risk factor? And there's another set of criteria that we need to look at as well, and those are Hill's criteria. And Hill's criteria really emphasize causation, because once you prove causation, and once you prove also that lowering the particular biological marker that we're evaluating to become a risk factor, well, then you've proved that it is in fact a risk factor. There are 7 different criteria under Hill's system. So perhaps the best study demonstrating that LPPLA2 is a risk factor, a true risk factor, is the lipid study. And in the lipid study, we found that a reduction in Lp-PLA2 activity during the first year was a highly significant predictor of CHD events and was independent of changes in LDL cholesterol. It also accounted for over half of the benefit of pravastatin in this lipid study. So we can see the dramatic impact that diminishing Lp-PLA2 activity had on events. And if you look at the top part of the slide, you can see that when Lp-PLA2 activity was dropped over 46.6 points, there was a 35% reduction in these events, which is highly significant. Our final section will be imaging, and we'll demonstrate how imaging is an integral part of the patient-centric evaluation which enables us to practice true interventional prevention. Why do we look for subclinical disease? Why do we evaluate our patients' vessels in order to see whether or not they have plaque before the plaque has manifested itself with a heart attack, stroke, or worst of all, sudden cardiac death? Well, the reason is that we know that plaque does precede the onset of events. So since our whole goal here is to block events, wouldn't it be nice if we could see whether or not a person had the substrate that would potentially lead to the worst end result, one of those events that I just mentioned? And there are several different modalities that we use, and I'm going to discuss three. And the three are CIMT, which is carotid intima media thickness, CAC, which is coronary artery calcification scoring, and CCTA, or coronary CT angiography. So we know that atherosclerosis begins very early in life, and we also know something very interesting, which is that most infarcts actually occur in non-obstructive lesions. Non-obstructive meaning less than 70%. This actually is one of the reasons why stress testing is such a bad screening test. Stress testing detects lesions that are greater than 70%. And if an individual has multiple 50% lesions, you're going to miss that on a stress test. And yet that individual is very likely at significant risk for a future cardiovascular event. When we do evaluate our patients' vessels and look for subclinical disease, the result is that we can actually risk reclassify them. So if you have an individual who you think is in the intermediate risk range and there's no evidence of vascular disease, well, that person can be risk reclassified a little downward, is at a little lower risk. But on the other hand, if you have an individual who has intermediate risk and you evaluate the individual for vascular disease that is subclinical, and you see multiple plaques in multiple territories, then you risk reclassify the patient upward. You know that that patient's risk is much higher than you would have felt. The other reason to do this, and I think we often downplay this, and I think it's actually very, very important, is that a picture truly is worth 1,000 words. So when an individual sees plaque sitting in his carotid artery or her coronary arteries, that individual is much more likely to follow therapeutic lifestyle changes, to take medications, and really to listen to what you're saying when you're trying to teach that individual how to live a healthier lifestyle. Here we see the advantages of CIMT. So carotid intima media thickness testing is a very easy test. It's accurate and it's reproducible. There's no radiation involved. It's non-invasive. It can be done in about 5 to 10 minutes, and it is predictive of heart outcomes. Here you see that as disease progression or thickness of the carotid intima media gets thicker and thicker over a period of time, so here we have 1 year. If you have greater thickness over that 1 year, then you have a greater likelihood of developing a coronary heart disease event. Next, we see on the left what a normal CIMT is, while on the right, you see that little bump on the inferior surface of the vessel where the arrow is, to which the arrow is pointing, and that is thickening of the intima media. This is somebody who has an increased risk of future cardiovascular events. Next, we move on to both coronary artery calcification and coronary CT angiography. And when we do that, we start introducing radiation. And when we introduce radiation, some people become worried, and those fears may be justified because there is an association between exposure to radiation and lifetime cancer risk. But here, this slide gives you a frame of reference, and I think that frame of reference is very important because when we order these tests, we should have some sense of what we're delivering to our patient. If you look at mammography, which is done very, very commonly, mammography delivers 0.7 millisieverts of radiation to a woman, whereas coronary artery calcification scoring delivers 1.5 millisieverts of radiation. And frankly, I said to a woman, the truth of the matter is men do have mammograms as well. But coronary artery calcification is about twice the radiation of a single mammogram, so it's really not that much. Coronary CT angiography, which used to deliver about 15 to 20 millisieverts of radiation, nowadays delivers between 1 and 3 millisieverts of radiation. So that too is not that much. Look at the bottom of the slide, and there's a very interesting statistic. And that is that living 1 year in Ramsar, Iran, an individual is exposed to 256 millisieverts of radiation. That is an enormous amount of radiation. And that's from radium in their mineral water. Yet these individuals do not go on to experience a higher incidence of cancer. Next, we see a very important study on coronary artery calcification scoring, and that was in MESA. And it showed that coronary artery calcium scores greater than 300 yielded a hazards ratio of 9.67, meaning that there's about a 10-fold increased risk of a cardiovascular event in an individual who has a coronary artery calcium score of greater than 300. That is substantial. The next slide is given to us care of Dr. Roger Blumenthal out of Johns Hopkins. And this too is, I think, a very illuminating slide. So what we see is 3 different individuals, all with the same Framingham risk score. Yet the person on the left has a calcium score of 0. There is not a drop of calcium in his blood vessels that feed the heart. Whereas the one in the middle, you see a small bit of calcium. Again, same Framingham risk score. But look at the one on the right. The one on the right has calcium in the left main coronary artery, the left anterior descending coronary artery, the left circumflex coronary artery, the ramus intermedius coronary artery. So this individual is at great risk of a future cardiovascular event, and yet has the same Framingham risk score as both of the other individuals. This is the advantage of coronary artery calcification scoring. Now let's take what we've learned about lipids and lipoproteins, biological markers, and imaging of subclinical disease. Bring it all together and evaluate a typical case that you'll see in your clinical practice. This is a 50-year-old physician with his first visit to the office. He has fairly average lipids, in fact a little better than average in that his LDL cholesterol is only 110 milligrams per deciliter, atypical chest pain, he's in suboptimal physical condition, he's overweight, his diet is poor. A doctor that he had seen prior to the visit with me had done a nuclear stress test which was negative. And let's remember that that nuclear stress test being negative simply tells us that he does not have a lesion in his coronary artery that is greater than 70%. He could have 50% lesions and he'll have a negative nuclear stress test. So we really don't know the status of his coronary arteries other than the fact that he doesn't have obstructive disease. His Framingham risk score was only 2%. So one might simply say this is a gentleman who needs no further attention, is at low risk, or we have the opportunity to use what we've learned and take a deeper look into the different elements that we've learned about, and then develop a much sharper image of this patient's risk. So next, we look at other lipids and lipoprotein and biomarker and risk markers and risk factors that will add to what we've already learned from our prior evaluation, our simple evaluation. So let's look at the highlighted figures. We have a triglyceride of 182, so that is high, but it's not terribly high, and that's part of a normal or a standard lipid profile. You wouldn't be sort of scratching your head now and saying, oh my God, this person is at deep risk of having an event, but look further. The LDL particle number is almost 2,200, and that is exceptionally high. Remember, an LDL particle number of 2,200, if you had that 10-to-1 relationship that you'd find in a population, would give this person an LDL cholesterol of about 220. Now, if you saw a patient with an LDL cholesterol of 220, that patient would likely have FH, or familial hypercholesterolemia, a very severe genetic disorder that can lead to premature cardiovascular disease. That is not what this patient has, but that's what you would be thinking. So the risk inherent in an LDL particle number of 2,200 is very high. The patient also has a high lipoprotein-associated phospholipase A2 of 273, a high myeloperoxidase, another biological marker, a high oxidized LDL, and a high urine microalbumin, which is kind of a poor man's guide for endothelial function. So now you're getting the sense, with multiple biomarkers and risk factors that are abnormal, you're getting the sense that this person actually is at great risk. And here you see a coronary CT angiogram of the left anterior descending coronary artery with multiple mixed plaques. So this person is at risk for cardiovascular event. So in conclusion here, the simple lipid profile actually failed to reveal this individual's risk, while knowing much more, evaluating biological markers, evaluating other risk factors, assessing for subclinical disease, justified far more aggressive management of what would have been an otherwise hidden risk. We have therefore illuminated the invisible in this patient. Our response then would be to really ramp up therapeutic lifestyle changes and utilize aggressive risk reduction with medications as well. Typically, this patient would be on a statin or combination therapy if necessary. Of course, aspirin, we'd consider ACE inhibition, the omega-3 fatty acids, DHA and EPA at 1,000 milligrams a day as per the American Heart Association recommendations. Obviously, weight loss and daily exercise, and this person definitely requires close follow-up. What we'll find is that the patient's numbers will improve, and they'll improve quite dramatically. So in follow-up, lipids, lipoproteins, and the biological markers will show total cholesterol of 110, LDL cholesterol of 53. More importantly, look down at the LDL particle number of 770 and the Lp(a)2 of 126, markedly improved from previous labs. So as a final thought, I'd like to say that we have entered the era of interventional prevention, and novel and well-vetted tools are now in our armamentarium and enable us to dynamically address and mitigate many of the root causes of atherosclerosis. And by doing everything that we've discussed today, this is how we practice preventive cardiology of the future, truly patient-centric interventional prevention. Thank you once again for joining us today for our discussion of interventional prevention.